Welcome to the Low Carb MD Podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low Carb MD Podcast is medical advice. Please consult your own doctor before making any lifestyle changes.
Welcome to the Low Carb MD Podcast. I have a great returning guest today, somebody whose research I've admired for a long time and somebody who's advocated for the type 1 community, which, as you all know by now, is a passion of mine. It's a group. Type 1 is an autoimmune disease, and of course, our guest, Dr. Andrew Koutnik, will tell you more about that, which affects the pancreas and really causes devastating outcomes over the long term. Besides the fear of tightly managing a blood sugar all day long, trying to get basic therapies, get basic equipment, can plague people with type 1, navigating day-to-day fluctuations of blood sugar all the way up from 400, 500 down to 50, fearing hypoglycemic shock, which is a lethal sort of complication of type 1. And then over the long term, fearing dying 15 years earlier than the average person, which is just a abomination, in my opinion. This is an absolutely ravaging disease. And I have had the honor of working with a team of 15 people to bring low carb nutrition into the forefront of medical nutrition therapy for type 1. And our guest today has devoted his entire life to advocating for type 1, being a patient with type 1, being a scientist with type 1, being a scientist that, researches metabolic health and how to improve the quality of life of type 1. Dr. Andrew Koutnik got his Ph.D. from the University of South Florida in molecular pharmacology and physiology. He's published over 60 papers in the metabolic health landscape. And most recently, he started with Sansum Diabetes about a year ago or a year and a half ago. And he told me this is the absolute dream job he could have. Even more recent than that, he published an amazing case report on a patient with 10 years of type 1 who use the low carb diet to maintain health. And there were some interesting findings there. We'll put that in the show notes. And he was also part of the IPTN guidelines that were just published, which I think every single dietitian out there dealing with type 1 patients, every single doctor dealing with type 1 patients needs to review. If you're a patient with type 1, you need to go download that guideline and give it to your doctor and dietitian. And he absolutely spearheaded that. So that was a long-winded way of saying I'm happy, Andrew, that you're on the show today. And I'm happy that you are who you are, advocating for this community that's really, underrepresented, in my opinion.
Tro, I always say it's an honor, but it really is. I was actually smiling when you first said type 1 diabetes, and then you went on to describe it pretty accurately and kind of the devastating nature of it. But I feel it's been the ultimate asset in my life journey. You even mentioned a few things in there. There's actually a number of transitions that have happened even since this point, with a lot of the things that I've been doing ultimately to try to position myself better to help people with type 1 diabetes. And so I appreciate that. Yeah, when we talk about type 1 diabetes, I think it's important for the general audience not to just be like, oh, I don't have type 1, I'm zoning out. The reality is that type 1 diabetes is a disease that provides incredible insight for metabolism. So what you'll hear about today actually is very relevant. In fact, maybe more relevant to understanding of metabolism than a lot of what you may hear in the general health space, because this is a disease where your pancreas no longer do an autoimmune attack. And there's a lot of science going into this that we don't fully have a consensus on how or what or why, but patients, due to what we believe is largely no fault of their own, get an autoimmune attack on their pancreas. The pancreas that produces insulin. Insulin ultimately is what regulates and controls blood sugar levels. The example I often give, because I think it's the easiest, is It's a lot like a thermostat. So let's say that blood sugar goes up, you give your thermostat for glucose releases insulin as it goes up, and as it comes down, it reduces the temperature or stops the insulin release. And so you have this kind of corrective mechanism, which is frankly life-saving for everyone. Blood sugar levels are kept in these very tight range, and medical definitions for normal is 70 to 120. Optimal is up for debate, but that's the medical definition. And your body does a damn good job usually of keeping it within that range until you develop disease. And in the context of type 1 diabetes, you lose all of that control. So now you are in complete independent control over your own metabolism. You now hold access to the most powerful hormone in the entire body, which, when injected, completely changes the entire all aspects, essentially, of metabolism. I would argue that anyone to say, oh no, it doesn't. I would argue it's the most powerful hormone. It's the most deadly, and you inject it not only all day, but you inject it at each meal of every single day, due to a number of, frankly, guesses as to what you will need for the amount of food you're consuming, the glycemic impact it will have, and beyond. So it's a very, very difficult disease to manage, but through education, knowledge, and just a general passion and interest in understanding metabolism, if you have that with this disease, it can be the greatest asset you ever have. My journey into metabolism in general and research, the greatest asset I will frankly state in my journey has come from, I will admit that there's a lot of power in academic education. It gives you incredible skills and tools and knowledge, but all that did was give answers to what I was seeing in my life every single day. I'm seeing changes in insulin sensitivity when I do this or when I do that. The list of things that change metabolism is frankly endless, but you see it and you live it with type 1 diabetes. And so you're very, very aware of what changes glucose levels, and you're very, very aware of what changes insulin levels. But everything you stated about the state of affairs in the context of type 1 diabetes and medical treatment is true. It is 100% expected that people with type 1 diabetes, due to variable and high glucose values, which is the average for most patients, are going to get at least one long-term complication, meaning retinopathy, so eye damage, nephropathy, kidney damage, neuropathy, nerve damage. These are expected to occur. These aren't the exception. They are expected to occur. This is unacceptable. And so the expectation that you're expected to lose 11 to 18 years off your life, that isn't some crazy high-end statistic. If I want to give you a high-end statistic, I would give you the years expected to be lost in underdeveloped countries across the world, which is 42 years with someone with type 1 diabetes. These are the average stats in the Western developed country where you have access to some of the best medical tools. And so it's important to appreciate a lot of the efforts that have come out of Tro, yourself, the community you're involved with, because there has been a general lack of appreciation for the potential of nutrition in the landscape of disease management, particularly for type 1 diabetes. There's a lot of people would argue the same for type 2, but for type 2 diabetes, this has actually been, there have been a number of trials, enough to where the American Diabetes Association has included it as one of, if not the most effective dietary approach for managing a number of the complications related to type 2 diabetes. They acknowledge this.
And I'd like to challenge that one, Andrew. I'm going to challenge that.
All right, shoot for it.
Because the ADA, first of all, everything you're saying I agree with, but the ADA has 4, basic medical nutrition therapies of their paradigms that they recommend as healthy, and 3 out of 4 are high carb. And when you dig into their guidelines, they do state, I think Yancey twisted their arm really, but they do state that lowering carbohydrates has the most evidence. But then out of another side of their mouth, they're saying calories and weight loss is the primary mechanism and macronutrient distribution doesn't matter. So my frustration with, if I, as somebody who's evangelized for 10 years for the type 2 community, the metabolic community, the obesity community, and really been an advocate for that community, I'll tell you that's not enough. But then when I read, when you put me on to the type 1 community and the real lack of support that they have about 2 or 3 years ago, when we had an initial discussion about what we can do. I was appalled that the ADA doesn't even have any guidelines for nutrition for type 1. And I found that this was, completely, I was surprised. So I'd love to hear you. I think that's what you're about to just come into and stop before before I interrupted. But I don't think that the ADA is as supportive as you say.
So let me clarify. I actually agree with you. I will say that it is completely confusing if you read a lot of the documents in their entirety, because with one statement, it is true. They do say that lowering carbohydrates is one of the most evidence-based strategies in type 2 diabetes, but then provide other strategies that are not cohesive with that, and guidance that are not cohesive. This is nothing you're saying is inaccurate. These are just facts. This is true. And this is someone who I've spoken with the ADA. I go to their conferences, so I don't have any bone to pick negatively with them. All I will say is that it's true. You're accurate. It is confusing if someone is looking for guidance on what they should do, to see that and then to see, hey, there's these other approaches that are mostly what are brought to the forefront of the conversation, despite the ones where reduced carbohydrates are the ones that are most effective. These are not cohesive. And maybe that's something that should be worked on, frankly. But I also will state that I have very publicly and during ADA webinars brought up the clear challenge that if the ADA, one, does not have, nor does really any major entity, have type 1 diabetes healthcare guidelines at all. And the problem with that is that I have heard from some of the best diabetes institutes in the world, from their healthcare team, asking me, how do we do this? We have a ton of patients who are doing this and we feel lost. Why would they feel lost, Tro, if there were guidelines on how to do this? Everyone knows what the ADA guidelines are because they're standard of care. And if you don't follow them, you're in trouble. So if we had guidelines for people where they didn't feel like they were having to do something outside of the scope of what is normal, and then they compromise their medical license, like no one should feel like they should have to do that. But the reality is, and I brought this up to all the major diabetes organizations, I have had conversations with all of them. And I have brought this point up. Look, we don't have guidelines and people are doing it at record levels. How do we address this? Because I'm not putting words in their mouth, by the way. I'm just stating this is just facts. And the problem, though, is that there is a set pathway for how these guidelines work, a set strategy, a systematic approach that doesn't accommodate for the reality of when evidence isn't at the level of something like types of insulin strategies or insulin pumps or CGMs that have had 4.5 times as many citations and publications in type 1 diabetes. That's just a reality. You have about 4.5 times less literature on diet in the context of type 1 diabetes. The irony of that, Tro, is that is despite the fact that we know that nutrition, specifically carbohydrates, have the most potent impact on postprandial at each meal glycemic control. This is a known fact. This is not controversy. This is not, I wonder if this is the case, or I wonder if that's not the case. Let's debate it. No, there's no debate here. Carbohydrates have the biggest impact. So if food has the biggest impact on managing glycemic control every day, it should be, in my opinion, at the forefront of the conversation about how to manage this disease, or at least a cornerstone of that. The reality is that technology such as closed loop insulin pumps, advanced ways to administer insulin, pharmacological, different insulin types, new drugs, or using drugs from other diseases like SGLT2 inhibitors, bringing them into the fold. All these things are at the forefront of what people are articulating and talking about, whereas diet having the most potential promise and impact. And we've talked about this in papers. The team's work on the Delphi methodology you guys recently published in the consensus for SMPH, if I'm saying that correctly, Society for Medical SMHP. There you go. I flipped that last one. SMHP, Society for Medical Health Practitioners, come out with a statement. Now, it wasn't so much a statement, but it was a methodology to actually look at the evidence that we have right now and come to a consensus with people who have actually lived experience. And that is a requirement where we're at right now. If we don't have 30 randomized controlled trials, at least 6 months in duration, that shouldn't preclude organizations from helping the patients.
I think now we have 3 randomized trials for either a moderate carb and a lower carb approach, randomized controlled trials in type 1 diabetes, and all of them, the lower carbohydrate approaches had, improved time and range. At least some of the surrogate endpoints were improved. So I think now in the past 2 years or year and a half, we have enough data to say, to at least not withhold, a low carb approach from a type 1 patient. And that's what that position statement said, hey, we have enough data not to withhold, and not to default to the dietary guidelines, which is a high carb, recommendation. I think that's the key. That's what I would wish every endocrinologist, every dietitian right now had. They knew that type 1 is a way to, TCR, lowering carbohydrates, is a way to, help stabilize blood sugar, improve time and range, and that shouldn't be withheld. It doesn't have to be promoted as an ideal, but it shouldn't be withheld. And you're absolutely right. I mean, and I want you to talk about this because you know more than anybody. The dietitians out there, they don't know what to do. The doctors, endocrinologists, they don't know what to do. So can you talk a little bit about, maybe the difficulties with changing the mindset in type 1 management? I'd love to hear you talk about that. Like, what are the barriers to, everybody doesn't have to do a, very low carb approach to managing type 1. They don't have to do that. But if we can acknowledge some basics that, hey, lowering your carbohydrates improves time and range, it does not cause, hypoglycemia if the insulin's managed. It doesn't increase, there's no evidence to increase risk of DKA. And, if you want to do it, we support that. Why can't every dietitian say that right now? I mean, is there any reason why they can't do that right now?
So I'm going to expound on all the things you just mentioned. Number one is that you talked about some randomized controlled trials. We as a team have pulled every single study ever published in type 1 diabetes that has reported a carbohydrate intake, confirmed patient or patients with type 1 diabetes, and a key long-term metabolic outcome that has association with long-term implications in the context of type 1 diabetes, like HbA1c, insulin, lipids, and beyond. That data has 17 reports in very low carbohydrate, less than 50 grams category, 17 reports in low carbohydrate from 50 to 130, over 30 in the moderate carbohydrate, and over 30 in the high carbohydrate range. There's a lot more literature than people actually realize is out there on this. And so hopefully in due time, that will become available. It's been a long process. We're talking about a half decade of effort into that work. So when that's out there, hopefully that will address a lot of these criticisms towards where we stand with the evidence base. You brought up the idea that dietitians don't know how to do this. So at blanket statement, if I was a dietitian listening to that, I'd be super pissed. Like, what is Tro talking about? He's that's unfair. The reality is that
do they manage insulin, like the minute-to-minute insulin? Like, I mean, a lot of them don't, right? You need a very specific dietitian, but you tell me if I'm wrong.
So what I will say is that you're actually saying evidence-based things. There's evidence that actually directly asks this question of dietitians in the healthcare setting managing therapeutic carbohydrate reduction, which is a term that describes this low carbohydrate, but more commonly used very low carbohydrate. Sometimes it could be a ketogenic diet, but it depends on how you do the diet. That dietary strategy has been shown to not. The evidence suggests when someone like Annalyn Conklin, she actually reviewed multiple clinics looking at how dietitians, one, do they feel like they can adequately implement this approach? Or two, do they feel, it was a number of other things, but these are the key take homes. Two, do they feel that their healthcare practitioner team supported them? And 66% of them said no to that. And so, no, they don't feel, on average, some are very knowledgeable. Some really do know what they're doing and they really get this. But the evidence right now says that they, one, are not even supported within their own practice, or two, they don't have the tools and strategies to feel prepared to guide a patient, particularly with a complex disease like type 1 diabetes, through this. And so it is not easy. Type 1 is a unique circumstance where you're dealing with a lot of very, very powerful tools. Like we mentioned insulin and how powerful it could be, life-threatening if you mismanage a dose at a meal, at an individual meal, and you're doing it every day for the rest of your life. So yes, it's not easy to do, and a lot of people would feel adverse towards overhauling the strategy. You also brought up the idea of the default to higher carbohydrate approaches. It must be stated that we actually don't have any evidence that the higher carbohydrate approaches are superior. In fact, the evidence we have right now that it should be going to review here shortly says quite the opposite. And that those approaches are not what is effective if you look from just looking at the spectrum of carbohydrate intake, not even a specific dietary pattern, just that macronutrient alone. When you move the needle, what is it associated with? And lower is associated with better. And that's the weight of all the evidence we have right now. So it is completely fair and actually evidence-based what you're saying, in that a lot of healthcare practitioners, specifically dietitians, don't feel like they can support a patient on this approach. And that's not entirely their fault. How can we judge an entire healthcare community who has no guidelines from their institutional bodies on how to do this effectively for patients when it's extremely complicated and complex? That's not an impossible ask, but it's a completely unfair ask. And I acknowledge that as someone who's been feverish and saying how big of a problem it is that patients don't get supported. Because what we've also shown from pulling all the evidence at this stage is that of those 17 reports on the very low carbohydrate end, so you have these different categories of carbohydrate intake, on the very low end, over half of those reports have shown patients doing this approach with minimal or zero healthcare support. So what is that doing for patients? What is that doing for patients that they have no access, or they refuse to receive access from healthcare practitioners? And I know that the healthcare practitioners that I've engaged with, and it might be biased because they're reaching out to me, they want to help. They want to help people. And the fact that they can't or don't feel supported is an absolute travesty. So the fact that your group has come out with a methodological approach with experts from the field to actually show this is an approach that should at the very least not be redacted from people, actually be something that they have autonomy and choice in their participation in. And in concert with that, I'm very appreciative that the timing of the work you guys did, because it also supports the guidelines that were put together. That's actually been almost a half of a decade, getting on to a full decade. So this actually stems, I don't know if you know this, Tro, this stems from the Society of Metabolic Health Practitioners, because Adele, who's a part of that, had brought up to a community group within the Institute for Personalized Therapeutic Nutrition the idea of, hey, how do we take this approach to type 1? It's such a complex thing. She was very passionate about it. Adele is no longer here with us, but she started that conversation, and that conversation then led to multiple attempts and iterations to move this forward. And I've talked to you off record about this, but that has not been an easy process. It has been a very, very difficult process about how, when, where, and it ultimately got to the point where it took a very passionate person, Beth McNally.
Yeah, she's great.
She deserves tremendous credit here for saying, I'm going to lead this effort because it's a lot of time and you're not getting compensated for that time. This is a truly altruistic effort that was, I say this before, for the community, by the community. Beth McNally is a parent of a child with type 1 diabetes. And she felt very passionate to the point where she has done many things that I don't know if she's told many people publicly, to help this community. I mean, like life-changing things she's done. And she was, in essence, one of the main, if not one of the sole reasons that it went from a 5-year effort to finishing through the finish line. So she deserves immense credit, along with the other team of supporters, Amy Rush,
Caroline Roberts, right?
Absolutely.
Oh, awesome.
So
yeah.
I will say that they deserve the vast majority of the credit here. I'm grateful that Institute for Personalized Therapeutic Nutrition were supportive of this as an entity, as an institute. But the reality is that this is just a start. This is an illustration for people to understand that there are institutional international guidelines that, experts from the field put together with lived experience on top of that And it was reviewed by over 10 people who fall within that same category. I mean, legit people from the field, endocrinologists, dietitians, certified diabetes educators, researchers from the space, who not only understand and oftentimes living with the disease themselves, who understand not just nutrition, but actually how to do this in patients with type 1 diabetes. And that's in essence the same composite team that you guys had, obviously with different people mixed into it for what you guys did in a completely independent effort. And it really is supportive of one another to illustrate that this is a strategy that people, number one, should be aware of, number two, should have access to, and number three, that healthcare practitioners and patients alike should have the ability to feel supported in this approach. There's no therapy on earth, Tro, that doesn't come with pros and cons. But that doesn't mean we should redact them or remove them from patients based on hypotheticals. What the evidence says to date is that it's an extremely powerful, if not the most powerful approach that you can implement. And I would be happy to have a collegial discussion with anyone who may disagree, and hopefully maybe a debate style setting, so people can see both sides of the argument and come to a consensus on this, because ultimately I think that will help move things forward. But that's the goal, to move things forward for patients.
The IPTN's document is absolutely amazing. I think that I hope somebody can take, it's a much more expansive document than what the SMHP did, but I think they sort of go together very well. One is a message saying this should not be withheld, and then the document that you put together, Beth McNally is a beast. Francisca is amazing. Dr. Caroline Roberts, amazing. All of the whole team there is great. And I think it gave the how-to, here's what to do. If you're a dietitian out there listening to this, if you're a mom or a dad of a type 1 patient, if you are a doctor out there who treats type 1, this document tells you exactly how. The SMHT document tells you why, but the document that you guys put together tells you how, and it's an amazing resource that I think, I wish somebody could put them together and say, here's the new guidelines, see you later, ADA. We don't need you.
Well, I love your, I have to say, I appreciate the candor. I hope that all institutions, regardless of where they stood in the past or where people feel about them, can come together to understand the nature of where we stand with this approach, and also understand that they hopefully would get behind providing their backing to, or their opinion on these things, not just kind of avoiding it altogether. I mean, that's an unacceptable thing for patients and healthcare practitioners. It's completely unfair to them. And so at the end of the day, I think there should be guidelines that come from all entities. And that includes the ADA, in my opinion. That includes many of these major healthcare, there's been some organizations that have been more forward with this, like Diabetes Canada. They actually were talking about this a few years ago in the context of type 1 diabetes, at least brought notice to it and talked about it. And here we are as we've done an international survey and with support with what was JDRF, now Breakthrough Type 1 Diabetes. And that was an international survey of patients and caregivers living with type 1 diabetes, with the goal of that data was because we were hearing from institutes saying, I understand you're saying this is an important thing and that people are doing this, but where's the data? I said, sounds great. We'll get it. And we'll ask that question. I mean, maybe it isn't a big deal to people. Everything I'm seeing, it seems to be. My lived experience certainly illustrates that. And we did that. And I will say that that's not prepared for publication yet, but I will say that it will very clearly demonstrate what has been known for a long time for many patients, that food is a huge part of the lived experience with type 1 diabetes. For many people, the most important part. And on top of that, the diets that people think people are currently doing are not what they realize. There's been a lot of assumptions that people are eating almost ubiquitously these higher carbohydrate approaches. And I think this data is going to maybe challenge a little bit of that patients are inadvertently finding themselves not doing those approaches, probably through lived experience, knowing that, hey, I want to feel better. I want to do better. Or whatever reason, it's not working for them. And so they're defaulting to other approaches, of which the lower carbohydrate spectrum is one of the most popular approaches that people are doing. And that's no surprise. It's no surprise when
what does that say about the medical community? And I know you don't like to disparage the medical community as much as I like to, but what does that say? When I read the 2019 pediatric paper, that, was the best, most read article in that year in pediatrics, really highlighting the case series from type 1 grit group. So if you're a type 1 patient listening to this, go to type 1 grit. It's an amazing Facebook group and community. What does that say when it's the parents and patients exemplifying, amazing care? I mean, I was looking at the average A1C of a patient with type 1 is 8. There's around 8.0. And the average A1C from that group was 5 and change. I think it was like 5.4 or something like that, or 5.7. It was like almost 2.5, almost 3 standard deviations outside of the mean, meaning like it was these just people with lived experience, parents who actually cared, who were performing in a way that the medical community has never seen. So what do you think it means when it's the patients leading and not the clinicians and scientists? What do you think that means about medicine and dietetics?
Well, I think there's a whole lot you're unwrapping. That could be a 5-hour podcast with controversy on the level of politics and maybe religion. And I think that it is so what you're referring to is a pediatric paper that showed it was 5.67. So that is on average, not in the pre-diabetes range, not in the type 2 diabetes range. That was a HbA1c on average that's in the normal glycemic range, at least by medical definitions. There's nothing like that in type 1 diabetes that someone can just go do tomorrow. Islet cell and beta cell transplant therapy, they all require immunosuppressants and major surgical implementation, at least currently. And so all those strategies are not accessible to the overwhelming majority of patients. And most patients regress, gain weight, HbA1c goes up. We have nothing like this, basically, is the way to say it. And so when this came out, I will actually contend that it did change things quite a bit. What it did is it actually it's told people this is a real thing and people are actually doing it. And that can no longer be challenged. They're doing it. And at least the patients that are doing it, at least doing it that way, are having a lot of success based on the numerical outcomes. The challenge, though, is that based on how people are taught, and I don't think it's inappropriate that these approaches to understanding what is effective and what isn't is challenged in this circumstance. So, for example, let's say the GLP-1 receptor agonists, which are drugs that are most known for their ability to manage obesity. However, they were really originally brought up because they were used for type 2 diabetes and were slightly less effective, or not, a lot less effective actually. But either way, so if you look at that as an example, let's say that you go through the scientific phase. So you have these cellular data, you have animal data, all this is saying it could be the next blockbuster drug. Then you get to, the actual clinical trials and you say, okay, a small number of trials, this is remarkable. You go to the big trial. Let's say at this big trial level, it literally killed 10% of the population. Then you'd say, oh, smokes, we shouldn't do this. Has actually happened before, not with the GLP-1 receptor agonist, but in other drugs. So it's taught to healthcare practitioners, researchers, et cetera, oftentimes that, hey, be careful in assuming that this data over here is immediately going to translate to safe, effective therapies down here. The challenge, though, so that a lot of people focus on that to a fault. So in the context of nutrition and type 1 diabetes, this specific circumstance, the weight of the evidence to date has largely focused on its overwhelming potential benefit. There's very little that actually supports anything to the contrary. And that's where we are. So we're at this kind of phase. I don't know if some people may just be listening and not seeing me, but I'm showing, a spectrum of, let's say, a 4-step process. The step we're at right now is around step 3. And we don't have, a trial that has, 1,000 people in it. Frankly, you're not getting it. Okay. You're not going to get that trial unless you have a philanthropic supporter in the billions throw a huge chunk of their entire assets to run a trial like that. I mean, these are pharmaceutical trials like that. They're in the hundreds of millions of dollars to pull that off. And who's going to benefit from a nutrition trial where everyone can go to the grocery store and just do it? Who's to benefit financially from that? And people turn that into a controversial state of affairs when they discuss that. But the reality is, like, it's understandable they're pissed off about that, and it's controversial because that's what gets done. That's why those tools and technologies and medicines, they're commercialized in the United States of America. That is incentivized. And as a result, it is advanced. And nutrition is largely pushed by the people who are benefiting, and that's the end user. That's the patient. And so a lot of the movement within the world of understanding nutrition better has come from the community themselves, who see the lived experience and say, there's something special here. What's going on? Why is all the focus over here and not on what's actually the most effective for me? And that is a frank problem. It has to do with how things are taught. I mean, there's not a whole lot of nutrition I'm sure you experienced this, Tro. Maybe you're the exception to this, that a lot of medical schools don't provide a lot of nutritional education, because why would you inundate someone with additional materials when they're already given more information that you could possibly learn at every cycle of the process through medical training? Obviously, I would contend that nutrition is one of the most powerful therapeutic tools, and along with exercise, I'll put it in the same category, for managing health, disease, and also there's the performance aspect of things in life. People want to perform well. Even if it's not Usain Bolt in a 100-meter trial, they want to perform better cognitively, physically, in their family life. They want those things. And nutrition and exercise are fundamental pillars for that. But that's not really taught in a lot of the settings where a patient will go to, let's say, a practitioner who isn't actually seasoned in that approach to gain that level of guidance. And that's failing both ends of the spectrum, frankly. And it should be incorporated into this. But there's a lot of reasons beyond what I'm speaking about why that hasn't necessarily translated, and why the medical community is having apprehension towards it, taking and advancing these approaches.
I want to come in on 2 points here because inaction from the medical community, right, has some repercussions. And so I want to highlight those. Forget about the A1Cs. We've talked about the A1C. We've talked about in type 1 diabetes and type 2 diabetes. We've talked about these things, but we haven't talked about the lived experience. And I want to highlight that. And this is something, that wasn't taught to me in medical school, certainly wasn't taught to me on my general medicine rotations. I've been an internist. We approach the mindset with which we approach type 1 or type 2 is sometimes very mechanistic, but the humanistic approach, the amount of comorbidity with depression, anxiety, living in fear of hypoglycemia, living like being concerned that you're going to die in your sleep because you had Fruit Loops and your blood sugar is 300 and you dosed 20 units of insulin, and now you don't know if you're going to make it through the night. I don't think that the average clinician, and certainly maybe it's my own naivety, maybe it was my ignorance that makes me think this way, but I've interviewed 300 clinicians and they're also naive to this information, but the amount of the mental health burden on a patient with type 1 is astronomical. So at the least, when we're considering therapeutic carbohydrate reduction, maybe in the absence of strong evidence, I think we have to step into that humanistic role as a clinician and as a community and say, this is not a way to live. Forget about the fact that you die 20 to 40 years, sooner than you should. You shouldn't have to live like that. You shouldn't have to live, like you're going to die in the middle of your sleep. That's not, it's just, I don't know how any doc out there can withhold this approach and be human and have those and acknowledge that lived experience. So I'd like you to talk about that. The second thing is, with this, you mentioned, and this is sort of what you really talked about for a long time, is this high degree of evidence that's required to change the medical scientific sort of guidelines, right? And I understand you're cautioning the listener, and it's a absolute. I mean, look at Vioxx, look at the opioid epidemic. You get something approved, and then mayhem sort of happens later on when things are used inappropriately, right? So absolutely. And one of the things I appreciate about the IPTN guidelines was you guys listed some contraindications, although they were very few and rare. You listed the contraindications, so kudos to you there. But in this, if you increase the degree of evidence needed to change, right, you create sort of stagnation. And in that stagnation is this human suffering that goes on. And in its absence, in the absence to change, and the absence of the medical community to find new, better, through clinical observation, which is what that pediatric paper showed, if you don't have the courage to take that leap, right, you don't have to state that these are firm conclusions how everybody should be treated. But if you don't have that courage, what happens is sort of industry takes over, and they put together huge trials with thousands of people to show that closed loop systems, are becoming better and better, and they are. The new Medtronic system, I just prescribed it. It's a miracle to one of my patients who now has an A1C of 6, who started in an 8, right? And their target is 100. So by doctors sort of ignoring medicine and ignoring the human experience, what I'm finding is, since the only beneficiary of producing that evidence is pharma and industry, the solution by default becomes pharma and industry. And you've talked about, food being such a powerful tool, but how do you as a scientist reconcile the fact that we will never have this data? We will never have the data to compete with industry or the device makers. And I'm not saying we have to live in absolutes and all or nothing. Like, here I am, a champion of diet, prescribing a closed loop, system. So I'd love to hear your comments about this. I know it's a complex, abstract, sort of multifaceted topic, but we got about 25 minutes. So maybe tackle them all if you can.
Yeah. So the first one, you brought the mental health issues. The data I've seen has shown anywhere between 2 to 10-fold higher risk after diagnosis for developing psychiatric diagnosis. I mean, we're talking things like bipolar disorder, anxiety, depression. I mean, these are all at much higher levels. The average is around 2 to 5-fold higher risk. But again, these are after the patient's diagnosed. We also know that variable, both high and low blood sugar, go Google it online, Google hyperglycemic symptoms, hypoglycemic symptoms. These are mental health symptoms: fatigue, irritability, loss of concentration. These are mental health symptoms. And so it's no surprise that a neurobiological change like glucose and insulin, which we know have powerful effects in the brain, when dysregulated continuously over the entire life of a patient, would have an impact. In fact, we know that there's data in children within 4 years of diagnosis, receiving average outcomes, even with standard of care approaches, develop brain abnormalities, specifically neuroanatomical abnormalities. And just even marginal improvements from the numbers you talked about in the 8s range, which the average is anywhere between 8 and around the upper 8 levels, based on most of the mean data in large population studies. If you just move it even marginally, I mean, not even below 8, just lower than what it was, you see neuroanatomical improvements in children. We also have data from the largest trial ever conducted in type 1 diabetes that, at least in children, the DCC and EDIC trial, you can Google that if interested. It was one of the most expensive NIH trials of all time in type 1 diabetes, that kids who had poor glycemic control or at least kids with type 1 diabetes, showed the inability to develop certain key areas of the brain during childhood. And the HbA1c level was associated with how poor the development was in those brain regions. And this was not like symptomatic assessment. This was MRI assessment of the brain. So these, and all data says the same thing. All data says the IQ is lower. All data shows these symptoms related to the variable blood sugar. There's no evidence against that. But I also want to then go to the next layer of this, which is your point about the level of evidence required. I want to just bring up that, yes, the gold standard would be to have 1,000 people, 700, like 500 here and 500 on this diet and 500 on the current diet that has been recommended for years, and compare it. We don't have to wait for that, though. That's just the gold standard. If you have that, it's better than the evidence over here that has less people and is less rigorously done. We have to just use the evidence that we currently have. And so that's just something for people to be aware of. That it doesn't mean we have to have that before we say, okay, we should do it. It just means that that's the best. But if we don't have that, you have to go to the next layer of evidence. For a lot of strategies and tools, if you have disease where they've done no assessment, let's say you have a rare disease where the only evidence you have is in animals. Should you ignore that evidence that there might be a therapeutic strategy that could benefit you just because it's only been in animals, not in humans? No, you should be using that first because it's the only evidence we have. It's the best evidence we have. The best evidence we have isn't, 500 in one group, 500 in another group, randomized controlled trial in type 1 diabetes for therapeutic carbohydrate reduction. But it's a lot of evidence. There's 17 publications in the very low carbohydrate range, 17 on the low carbohydrate range, over 30 in moderate carbohydrate. Like we have plenty to go off of for today to have this discussion to say that reduction in carbohydrates is associated with improvement in glycemic control, reduction in insulin. And a lot of patients view this as restrictive out the gate. Like, hey, most clinicians do too. So this is part of the barrier for a lot of patients is that, hey, you just got diagnosed with a disease that is largely believed to not be your fault. And you have all these changes and limitations on your life. You're going to have to now take insulin everywhere you go. You're going to have to inject it. Historically, that meant pulling a syringe out in public and shooting it into you, the stigma that comes along with that. And depending on, you have to be a world expert on nutrition. If you're not, you're going to find out how quickly it matters. And you better figure it out quick because you essentially need to be a world expert on that. And you're going to live through almost every experience that will change on glucose and insulin and wonder why one day is completely different than the next, or why one meal is completely different than the next, even if everything is the same, or at least it appears to be. You're going to learn all of that. And for the patient, the lived experience for them on this journey, they often viewed, the high carbohydrate approach or low carbohydrate approaches, let me say this differently, as a restriction. But the philosophy needs to be assessed from multiple perspectives.
Oh, I'm so riled up right now. I'm going to tell you, I'm so riled up right now. But go ahead.
Yeah, I would love to hear your take on this. I will just say that living with a disease that affects how you feel at every single meal, every fluctuation up, all the variability will affect your quality of life. It will affect the people around you. These are not overt. Sometimes they're subconscious changes in how you act and how you feel. And that's not because you don't try. It's because you're trying your hardest. The tools aren't able to effectively manage it with the current dietary paradigm most people are eating. And you're just stuck with that. And you're told that's what you should do. However, what if there was another approach that dramatically reduced the variability in your lived experience? You now have the option or potential for stability in your life. You only eat a meal. Sometimes some people, they eat it within 5 minutes. Some people it's 30 minutes, but most people eat, a bunch of snacks. So we could go into data on that, but I'll just say typically we're talking about breakfast, lunch, dinner. Those are usually like 30 minutes or less sessions. That's an hour and a half. Should an hour and a half in your day, if you change that hour and a half and what you do in that hour and a half, be seen as more restrictive than what you do in that hour and a half, improving the other 22 and a half hours of your day and your chronic outcomes and how you feel and your risk for comorbidities and 11 to 18 years shorter lifespan? I think people may be viewing this. I'm not telling you they're wrong. What I'm saying is that maybe we should be reevaluating what restrictive is in the context of diet, because how it has been previously framed puts the onus on, I'm changing it and I can't do this one thing. What if changing one thing gives you 10 things? in your life. What's the trade-off there? And is that restrictive? That's not talked about, and it should be.
So I want to tell you a quick story, and my wife has been a supporter of me. Mine was throughout our entire relationship. 20 years we've been together, and we've been married. Oh gosh,
Good for you guys.
14, 15 years. Okay, we got three amazing kids. And when she noticed I had issues with sort of binge eating and food addiction, she's like, she leaned in. She's like, let me help you. And she made a lot of quote unquote, low carb bombs or whatever, low carb treats and stuff like that. I was binge eating pizza. She would make me pizza, using almond flour or cheese and whatever. So she's just been absolutely like a miracle for me. I haven't had to deviate from my diet. I've never felt restricted at all. I've been able to keep 140 pounds, 150 pounds, 145 pounds off for over a decade. Anyway, one of my patients has a kid who has type 1. He was diagnosed at a very young age, 4 years old. He's now 10 years old. Our kids are the same age. So I told my patient, just bring your whole family over. And obviously we knew that his son had type 1. So my wife, went like all out. I mean, the kid, like you walked in there was Quest chips, there was crackers that she made out of almond flour. I mean, there was vegetables that the kid could pick. And, we had a barbecue style thing with buns that were low carb, with ketchup that was low carb, no sugar added. Every single, side was low carb. And then dessert was low carb. All the desserts, the cookies, the rainbow cookies, everything was low carb. And then, we had a campfire with the kids. There's like 9 kids there, basically. So 8 kids there. Had a campfire with some low carb marshmallows. And this kid felt like, he told his dad on the way home, and his dad shared it with me. He's like, I've had diabetes as long as I can remember. And I've never felt like I could just go and eat anything, do anything, and not have to worry about my blood sugar. And so when I hear people say that, like, oh, it's restrictive, I'm like, that's BS. That's BS.
It's education. I mean, everyone needs a friend, a family friend, like
yeah, my wife is
like you guys. Yeah, I appreciate you sharing that story. First off, thank you for doing that for that patient. Like
he's not my patient.
For that patient.
Yeah.
For that patient in general.
Yeah.
For me, that is education. And that's a lot of what the effort SMHP has put out there. That's a lot of what we're trying to do with the guidelines, is just provide education that it's possible. And it's not like it hasn't been out there. There have been some super advocates who have spoken publicly despite the negative recourse they've had for being advocates in the first place. There are many. And a lot of them are actually helped with the effort you guys had, and they should be credited for what they've done. Like for example, that gentleman named Dr. Richard Bernstein has been viewed very negatively from the traditional community, but the reality is that should be reevaluated. That should be reevaluated for what he actually did and the onus he took and the stake he put out there at a time when a lot of people viewed that as kind of not only fringe, but like wrong. And I will just tell you, the evidence that we're seeing right now and looking at all of it is not supportive of the way that he was viewed or treated.
Yeah, I mean, it's not restrictive. I mean, that's this idea that it's restrictive. It's in the context of an industry that has not supported therapeutic carbohydrate reduction, but now there is. And I think, look, I'm not in the sweetener business, but there's companies, that like, RX Sugar, which I think that you're on the board for, and they make allulose, right, which is a non-glycemic, sweetener that, people with type 1 can absolutely use and lean on, right? And they can have, they can partake in those birthdays. They can partake. I got no stock in RX Sugar. Even I would argue that I've had, quibbles about some of the claims, scientific claims that have been made about its, GLP-1, promoting properties. But I think if you come back to that humanistic experience from the type 1 patient, it's a godsend, right? It makes it so that this diet is not restrictive for people with type 1, for people with mental health disorders that are using therapeutic carbohydrate reduction. And so I think we're seeing more and more of a community out there of industry partners that are making it easier. And it's alarming to me that, some of the dietitians and doctors can't lean in and get over that idea that this is restrictive. So I'd love to, you've lived it. So you tell me, do you feel restricted? Do you think that there's a valid sort of criticism, that it's a restrictive way of eating?
Yeah, I love to unpack that, but I want to go direct to your question. The reason I do it is because it frees my life. It has made massive implications in a positive way for my family. My wife's not waking up in the middle of the night because of highs and lows, wondering, okay, is he safe? Did you check? And then that creates pattern. Like, okay, even when blood sugar is stable now you're still waking up to try and check those things. Just like your wife, my wife has been insanely supportive of this, to the point where I remember I checked my blood sugar one day and I was like, yeah, that's not what I wanted it to be. She's like, you should own that. And it was my HbA1c. I said, you should own that and put it out there publicly and then fix it. And I said, oh, okay. Okay, let's do it. I didn't want to, I was not planning to do that, but she was the one who actually said you should consider that, and she was the one advocating for that. The idea of restriction around this approach has been the opposite. Like, if it was really that terrible of an approach, people would not be doing it. You'd find a better approach, and that's the whole point here. I want to state this pretty loud and clear, and people aren't going to believe this, and that's fine. But I am an advocate. I'm not an advocate of any one diet or any one medicine or any one approach. I'm an advocate for what works for patients to live their best life. Would this approach that we've been discussing throughout this talk be the best thing ever for every patient on earth? Maybe not, but it could be life-changing for many. And so that's an awareness that should be out there, and life-changing in a way that what you're describing, it can be freeing for people. The reality here, Tro, is that a lot of people don't pay attention to, like, oh, wow, it's like obesity and type 2 diabetes. Most people are not actually changed. People are going to disagree with this, but this is just a lived experience. I was obese as in adolescence, and I was also lived experience with type 1. I didn't change my obesity because of all this data saying that I was going to live with much higher risk for comorbidities. I did it because I felt like shit, and I looked like shit. That's why I changed it, because I wanted to change how I felt about myself. I wanted it because I wanted that in my life. I didn't want to feel terrible about who I was. And so I fixed it. So in the context of type 1 diabetes, I did it not because I was like, oh, I'm going to do this so it fixes all these long-term complications. Like, you don't think that. Humans don't think that far. They're like, I don't want to feel terrible after this meal. Like, I do a lot of self-tests. I just love that type of stuff experimentally. And, once in a while, I'll self-test a comparison or control of the standard approach. And it's a journey, Tro, because I have to place it within my day to where it won't ruin it. It's because a lot of people think, oh, no, I feel fine. It's like, but have you ever been completely normal glycemic before for at least a couple of weeks to know what that feels like, to understand what fine is? Have you had a comparison yet? Do you know? And that's what I encourage every patient to do. Just try different things, try new strategies, continue to feel curious to improve your disease. Don't feel like you can't. You can. You absolutely can. You can
how long should they try, do you think? If you had to give, so somebody's listening right now, they have type 1, they have a kid with type 1, and they're like, Andrew Koutnik, Dr. Andrew Koutnik, he inspires me. He has type 1. He's an exercise beast. His arterial stiffness is amazing, because they read your paper. So how long should they try, to self-test before they come to, what do you think is that, should it 3 days, 2 weeks, a month, 2 months, 3 months? What's try to you?
Until you get normal glycemia. until you know what it's like that you see all these other patients over here who have these flat glucose levels. I mean, I can just tell you, for all those people, it's not perfect every day. You know, I have on average an HbA1c in the normal glycemic range for over a decade using this approach, but it's not perfect every day. It's not every day is perfect. You are constantly working to navigate. It's way better, way better, but it's not perfect. So there's no set timeline. Some people, we know that at the very first meal that you go low carb, you're changing the glucose input and the insulin requirements of that meal. It starts at that first meal. So you can see change instantly. And in fact, most patients have experienced this already. I'm sure every patient has had some type of meal that's on the lower carbohydrate range. This might have been like a protein and fat-based meal. Maybe they had some just like lettuce or veggies that were very high fiber type of vegetables. I'm not talking like a potato here or rice. I'm talking like, you know, the spinach, kale, cauliflower, zucchini, one of these other strategies, right? And they're like, wow, I didn't need much insulin for that. So most patients have experienced this. Most patients have had a salad somewhere with some like salmon or chicken. So most people have experienced that before. The experience that I'm talking about is the lived multi-day, multi-week experience of seeing what it feels like and seeing how it changes your life, being mindful and paying attention to how that feels, and then being mindful what happens when you're not there. And I think that's an empowering experience. A lot of people have pushed back against things like CGMs for the general population or people who don't have type 2 diabetes or type 1 diabetes. And actually some of that's come from the type 1 diabetes community, which I think is absolutely absurd. The idea that you have an innovation that came out of your disease shouldn't be able to help other people is ridiculous, in my opinion. These are powerful tools that can help people understand and associate, oh, I feel a certain way. Maybe that's because I went to like 180 and I came down to 100 in like 30 minutes. Maybe that's because of the huge insulin bolus that came along with that. You can start being informed and start associating, oh, that change is associated with something I feel. In type 1 diabetes, we've had these tools for almost a decade, insulin and glucose at the same time. And if you pay attention, you can start to understand how much easier it is when it's not like ups and downs, highs and lows. In fact, a joke I heard from an elite level professional athlete with type 1 diabetes is, well, if I never ate or exercised, everything would be perfect. And the truth is, yeah, if you don't do anything that's challenging, it'd be perfect. But there are tools and strategies, obviously, that allow you to eat a nutrient-dense, healthy approach that don't compromise you. Number one, those are on the table. The evidence says that they're on the table. And there's also ways, exercise is a more difficult complication, or not complication, but a more difficult thing to navigate in type 1 diabetes. And there's really frankly, there's no evidence or guidelines outside of the lived experience of patients with type 1 diabetes on how to approach low carb in exercise and management. That's an open can of worms, and it's going to need to be addressed soon. And I will start doing that more publicly in the near future, because it is a big gap for patients. But all I'll say is that at present, it's for a lot of people, it's freedom. It's freedom from a disease that affects every day of every moment of your life. In fact, there's a diagnosis called diabetes distress that is quite literally made up from the origin of this disease. It was developed because of type 1 diabetes. Diabetes distress comes from type 1 diabetes. It is its own diagnosis that didn't exist, obviously, without diabetes. And so what we're talking about here today, Tro, in summary, is just an awareness of an evidence-based strategy from the evidence we have today for modulating glycemic control and insulin in patients with type 1 diabetes, and the impact it could have, the restriction that has been assigned to it, are all things that are all in the eye of the beholder. And it's important to hear opinions from people who may not see it the way that you have been taught about it traditionally. And again, if people are interested, just like anything in type 1 diabetes, usually if you want anything to go well or to have any level of control, you got to often give it a go and just try, take the first step in doing that. And in your team at SMHP, IPTN, the guidelines that have come out, there's a lot of type 1 grit as a community, the Bernstein book, Diabetes Solutions. There's a lot of tools out there if patients want to learn about it before they jump into the deep end. And that's probably wise. But just know that if you don't take the first step, you'll never know.
Yeah, I mean, wise words, and so many gaps to fill, absolutely, with exercise, and managing that, infections, these, stressful events. These are such hard things to manage, and even things that maybe most clinicians don't even realize, sleep disturbance and how it affects insulin needs. All of these things sort of culminate into making type 1 so difficult to manage. So none of these are answers or solutions by themselves. They're just, I agree with you 100%. They're these small changes that you can make and experiment and learn more and get resources you need to sort of help you on your path. And I'm grateful, Andrew, that you came on today. I know it's a weekend and you got 2 kids, and I'm happy that you keep doing, you're just a warrior in the type 1 space, and I appreciate that. And I appreciate you, being an advocate. I think doing it in a way that's maybe less abrasive than me, but nonetheless, you're appreciated by many people, and we relied on a lot of your work to publish that statement through the SMHP. And others like Belinda Lenners and so many others, Bernstein. And so thank you for coming on, and thank you for doing what you do. And thank you for being open about things online and showing people sort of what you do. I think that that's absolutely, the most important thing I think everybody in this community, in the metabolic health type 1 community, can do, is just show people what they're doing, and the proof's in the pudding. So thanks for coming on.
Thank you. It's been an honor. And I will say on that note, it was the one apprehensive thing I've had in this space with type 1 diabetes is to put myself out there publicly and speak about this. And it was actually a close friend of mine named Max Domi who pushed me to actually, with him, do a transparent, open conversation on a podcast format that's completely public to people, because he is a professional athlete living with type 1 diabetes. This has been transformative for his life, and just the awareness of how to, what should I do and what not. And he felt that it should be available to everyone. And so I'll just say that I appreciate your comments on that, because it hasn't been an easy journey to put things out there publicly. It wasn't my default. I see a lot of problems with social media and the implications it has, but I also see it as one of the greatest tools of all time to reach people and help people. And so that's why I do it. I don't do it because it's necessarily going to make me feel good every day. It usually doesn't always do that. But in a lot of ways, it's the most powerful tool that one has to reach people for messages that could help them. And that's really the goal here. Once I do that, and I feel like the things have improved and changed in type 1 diabetes, maybe I'll hang up my hat and move on to other things in life. But until that's happened, this is what I'm doing.
Not to be pessimistic, but I think you have a lot of work ahead of you. Takes a long time for docs to change. So, but I look forward to everything that you're doing and everything you're going to do.
I appreciate it. Honor.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.